for our afternoon speakers.
For Ms. Kirkland, what Carl was going to ask, but we unfortunately had to leave, was, is there actual studies and proof that the cancer up in Alaska or the workers from the Exxon Valdez case, that cancer is actually...
No, that was a misunderstanding. It's not the Exxon Valdez, it's World Trade Center. Exxon Valdez was kind of, they were saying 90% of the workers had died because of their exposure to dispersants.
Okay.
And when I checked, Exxon Valdez, half the labor force was union, half the labor force was locals. So I don't have anything, I have no information on the locals. I do have information on the union workforce. And what the one person told me was, no, not only are 90% of them not dead, 90% of them are still working. So, that was a big, that's a big difference.
Okay.
So yeah, no, but World Trade Center is where we're finding 10 years out that we're getting cancers. On dispersants, we have nothing, and of course, Exxon Valdez didn't use that much in the way of dispersants. By the time they got the dispersants up there, that they figured out that what they were doing was kind of, one of the speakers said, they learned a lot about what not to do, and dispersants were one of the things they decided not to do after the other errors. So yeah, no, I'm sorry if you misunderstood that, yeah.
Thank you.
Also, Ak-Heidi, you mentioned how there's just not a lot of that expertise spread around to all the local communities. And I've heard, I'm not sure if it was a response or training, I think it was an actual response where somebody had worked, I guess, with the local government to set up kind of like an on-call nurse type of a thing because there was such a big community impact. That may have been the ITTC in Houston. But they tried to set something else up instead because there was a lot of people, instead of everybody just rushing to the emergency room, there might be something going on. They tried to set up like an on-call. And I thought it was a great idea, but then you look at who would actually be the person running that, and would they have the background to really, from an exposure standpoint, have the knowledge base to accurately, give that information. I was just curious what your thoughts would be around something like that.
Yeah, what you have to have is the resources to have, like somebody like the University of Illinois Chicago, which has a training program both in occupational medicine and in toxicology and in emergency medicine, to be able to answer the calls from those folks. And what we try to do in my organization is have the calls come in from the primary care providers, be it a nurse practitioner, physician, PA, and then respond to them so that they know not only, because what happens then is they not only know how to respond to the first patient that they saw, but then they've got an idea of what to do with the next three. So that's what we try to do.
I don't know if the effort of maybe trying to get ahead of that to just give somebody pre-information of, if you're feeling this, and this, absolutely go to the hospital. There's just so much out there, especially if you have a large atmosphere.
Yeah, and and one of the problems you run into with that is affectionately referred to as med student syndrome, is if you put out all the symptoms that you should go to see your doctor,
Oh, yeah.
they start getting them. Yeah. So we try to respond, and be ready to respond. So when something happens, we've got somebody on call who can, understand what those situations are. And so that's one of the things that we try to track. There was a lot of concern when the nuclear power plant in Japan blew up. And there were people on the West Coast who were panicked that all this nuclear waste was going to go over. So happens one of our physicians is Ukrainian and responded to Chernobyl. And so we asked him, to brief our physicians on the West Coast as to what sort of questions they might get. And he was available if they had further, but he at least briefed them ahead of time. As soon as it blew up, he said, this is what we need to be able to do. So, yeah. We try to be proactive, but sometimes you can't.
Thank you.
Yeah, I just have a question for Dr. Yale. Preparedness. prepare to respond, or prepare to prevent, or prepare where, if you had
Yes.
$100, where would you put it?
Obviously, prevention is worth the pound of cure. Now some prevention is worth the pound of cure. So certainly prevention is important, but we know that we can't prevent everything, so we need to be prepared. And so that's, again, my message is just be prepared for when things that you put in place to prevent something happening, when they fail, be prepared to do something else. So yeah, we like to prevent, but we know we can't prevent everything, so we need to be prepared. And most of the time, where it happens so technological disasters are so unexpected. Don't really we don't really have a lot of warning time. They just happen. So by then, it's too late to prepare. So have your expertise identified, have them trained, whether it's medical, mental health, social services, economic services. There's a whole range of areas where you can be prepared. And the other thing about preparedness is it helps the community, not just when a hazard event occurs, but it lifts the community up when there's nothing threatening them. It just helps build community relationships and resources, social capital, cultural capital, things that are really the strong ingredients for a resilient community. So I see preparedness as part of just uplifting the entire community to be more resilient.
Anyone else? Steve?
Bill, I had a quick question, but maybe a long answer, I'm not sure. But, you know, you studied technological disasters all over the world, and in some cases, I would assume some places you've seen more corrosive communities than others. I didn't know if there were some factors that you saw where you would have expected it to be more corrosive and it wasn't. What are the differences between, like, for example, Cordova is a pretty corrosive situation. Are there some things that we can think about in the Gulf and nationally and Mississippi Alabama specifically that differentiate those factors?
Well, I
That's a
think,
long, that might be a loaded question too, but I'm just trying to think.
I think part of what made Cordova more susceptible to the corrosion was its relative isolation. You can't drive there, you either fly in or get in by boat. It's relatively small, so it's very insulated from. So I would expect more corrosion in smaller, more insulated communities. And then I would expect more corrosion when there's greater uncertainty about what's going on and what the impacts are. So when you have multiple entities offering competing definitions of what's going on and really creating even more uncertainty, that's where the corrosion is more likely to occur. So it really has to do with maybe the isolated nature of the community and the degree of uncertainty and competing definitions of what's going on that would make things more corrosive or less corrosive. The corrosive community is in comparison to the therapeutic community that we typically see after a natural hazard event where community members pull together. In Oklahoma, we had Moore Strong after the Moore tornadoes 6 years ago. And you just rally around each other and you lift each other up. There's some exceptions, but that's not what we find typically in technological disasters. Too much uncertainty and competing definitions.
Any other questions? And I do want to let you guys know we've got a 1-pager and an 8-pager pub out there, because I'm a sales lady today, that do talk about impacts of technological and natural disasters on communities and community resilience, where there is some discussion there about the difference between these therapeutic and corrosive communities. Let's thank our panel.